All right, welcome to today's recorded lecture. This lecture will be going over chapters 40 and 41 in the Fundamentals textbook. Because I am in the office today and the Wi-Fi connection can be intermittent here, I am not going to load the PowerPoint as I'm. So if you want, you can go ahead and start your recorded lecture, minimize it, and then you can listen to me as you go through your PowerPoint at home. All right, chapter 40. One of the most common physical care problems that plague the older adult population are impaired mobility, alteration in elimination, alteration in nutrition, sensory deficits, and polypharmacy. Please take note that the number one most common physical problem plaguing the older adult is the impaired mobility. Sexuality concerns are also common. Decreased mobility can lead to numerous complications for our older adult population. Diseases that interfere with adequate circulation and oxygenation will contribute to altered activity tolerance and immobility. Poor nutrition can result from immobility or the lack of energy to obtain or prepare food. As nurses, we need to immediately address these mobility concerns so that we can quickly get the patient back to their former level of activity and avoid any potential complications. Educate the older adult about engaging in lifelong activity to maintain optimal mobility. It has been proven that walking 30 minutes a day is beneficial to health. Performing this activity even 3 times a week is better than not walking at all. Strength training with resistance exercises, like free weights and weight machines, have also been shown to decrease the risk of osteoporosis, muscle wasting, and lower as well as diabetes. Dancing, gardening, home maintenance, and swimming can be activities used to promote mobility. Participating in craft activities and arthritis programs can also help preserve fine motor movement. Menopausal hormone therapy, or MHT, can be used with combinations of dietary supplements and weight-bearing exercises to prevent osteoporosis in women. MHTs do have potential side effects, including the risk of breast cancer, heart disease, blood clots, and stroke, making its use controversial. Anti-inflammatory maintain mobility. The period of bed rest during illness should be as limited as possible for our elderly population. Even transferring a patient from the bed to the chair will have beneficial effects. Assist the elderly patient with passive range of motion when they are too weak to perform the active range of motion exercises on their own. Passive range of motion exercises will help maintain joint flexibility and prevent muscle wasting. With hospital stays being so short, we need to begin our efforts to restore the patient to maximum mobility potential as quickly as possible. If the patient is too weak, we can seek a physical therapy or PT referral. The nursing home setting will allow the nurse to monitor and promote mobility over an extended period of time. All patients should be considered for assisted ambulation unless there's an underlying condition or illness, such as paralysis or severe cardiac disease. The older adult who is not ambulated will deteriorate and eventually be unable to walk. Many patients would rather risk a fall than be placed in a wheelchair. Falls are one of the most common safety problems for our older adult population. For patients older than 65, falls are the leading cause of fatal injuries, non-fatal injuries, and hospital trauma admissions. Falls can cause hip fractures or traumatic. It has been demonstrated that assessing a patient's risk factors for falls and developing targeted nursing interventions based on that assessment are effective strategies for fall prevention. Changes in the older adult's posture, balance, gait, and vision contribute to the risk of falling. Environmental factors like clutter in walking areas, inadequate lighting, glares in lighting, improper footwear, and unsafe furnishings like scatter rugs will predispose the patient to falls. Even walkers and canes can increase the patient's risk of falls when not used appropriately. Medications frequently contribute to falls. Sedatives, hypnotics, and tranquilizers can decrease a patient's alertness and slow their reaction time. Diuretics, antihypertensives, and antihistamines will increase their risk of postural or orthostatic hypotension. This is an unusually low blood pressure upon standing or changing positions. It can cause the patient to become lightheaded and predispose them to fall. Most falls occur in the bedroom or the bathroom. It's important to assess the home environment to see how the patient will navigate these areas while performing their activities of daily living. Perform patient and family education about any risk factors, as well as measures to reduce or avoid falls. If the patient is cognitively impaired, implementing a toileting schedule to discourage self-toileting and a potential fall can be very beneficial. Do not leave patients who unsafely attempt any of these actions unattended. Move your older adults slowly out of bed to prevent any possible orthostatic hypotension. Utilize elastic support stockings to prevent or lessen any hypotension. Place the call light so it's readily available to the patient who is in bed, in a chair, or in the bathroom. Keep the patient's bed in a low position with the brakes engaged unless you are directly at the bedside. Answer call lights promptly and avoid unsafe attempts to stand or walk. Maintain clear walking paths, adjust lighting, and wipe up any spills from the floor promptly. Use protective devices only when there's a documented reason to do so and only after the patient and guardian has given their permission, as well as an order by the primary care doctor has been put into the record. Protective devices will include waist devices, safety belts, and Jerry chairs. Perform patient and family education about hazards in the home and how to prevent falls in the home. If the older adult is being discharged from the hospital and they live alone, make a referral for a member of the healthcare team to assess the home for any potential safety hazards. Always discourage our elderly population from climbing a ladder or sitting on a chair to reach high places. If their balance is unsteady, instruct them not to reach for any objects above their head level. Therefore, they should organize their materials and things at home so that nothing is above their head level to reduce the risk of any falls. Devices to assist with reaching can also be purchased to avoid the temptation to reach overhead or stand up on a ladder or stool. Incontinence is one of the most common reasons that older adults are institutionalized. Embarrassment, social withdrawal, depression, and low self-esteem are common for the older adult who is incontinent. Urinary incontinence is not a normal consequence of aging. Incontinence can be the result of an acute condition or a chronic problem. Temporary incontinence can develop as a result of acute illness. An underlying cause should always be sought out when incontinence occurs. Management of incontinence can be frustrating for the patient and the nurse. Treatment is based on the underlying cause and includes medication like oxybutynin chloride or doxazosin mesylate, which will relax the smooth muscle of the bladder or the prostate. Herbal approaches also include the use of saw palmetto and pumpkin seeds, which can possibly reduce prostate swelling. However, their effect has not been proven. Treatment can also include surgery or behavioral interventions. Some behavioral approaches to urinary incontinence can be seen on page 837 in box 40.1. Take note of the bladder retraining, prompted voiding, and of course the habit or timed voiding. All of these can be very helpful in treating the patient who is confused and incontinent. You can help prevent skin breakdown by keeping the patient who's incontinent clean and dry and by using a skin protecting product. The use of easy release clothing, protective pads, and condom catheters for men can hinder skin breakdown, avoid the soiling of bed and clothing, and prevent any embarrassment for the patient. Encouraging fluids can decrease the urine concentration so that it is less irritating, less predisposing to urinary tract infections, and less odoriferous. Assist the patient to the bathroom at regular intervals. This is one of the most helpful strategies for reducing patient falls. Constipation is a common problem among the elderly population. Before deciding whether or not constipation is a problem, always assess the frequency, amount, and consistency of stools and any possible contributing factors. Remember, like how we discussed in lecture, that one person's normal may not be the same as another person's. Always ask them what is normal for them. Fecal impaction can develop rapidly in the ill older adult, especially while on bed rest, and who is receiving pain medication while also not eating a normal diet. Careful record keeping of bowel movements, especially in those patients with memory impairment, is an important prevention of fecal impaction. Signs and symptoms of fecal impaction can include abdominal cramping or rectal pain, abdominal distension, the passing of small amounts of liquid stool, and the loss of appetite. Digital examination of the rectum can possibly reveal a mass. It's important to check whether an order is required at your institution before performing this procedure. Within Baycare, nurses are not allowed to do fecal impaction. It's usually left to the doctor, NP, or PA. When checking for fecal impaction, you would perform digital rectal examination with caution, especially in our patients with cardiac disease. Digital examination of the rectum can result in an unusually low heart rate because of vagal stimulation. A low heart rate could lead to a cardiac arrhythmia and possibly cardiac arrest. This is one of the reasons why it's contraindicated for nursing or other personnel to perform this, and also a reason why we designate that to our upper level providers who have more education and then can assume that liability. Along with interventions for constipation, patient education should include specific diet remedies like hot water and lemon juice first thing on waking up, prunes, prune juice with a carbonated drink, bran cereal, whole grain breads, roughage like raw fruits and vegetables, and fluid intake of at least 2,500 mLs per day. Encourage the patient to adopt an acceptable exercise program and invite them to heed the urge to defecate quickly to avoid any potential problems. It's recommended that our older adults reduce their sugar and fat intake and increase the roughage in their diet. Our elderly population should also be increasing their absorption or consumption of calcium and vitamin D. Calcium can lead to bone demineralization and osteoporosis when deficient in the elderly adult population. A lack of vitamin D can lead to bone demineralization. Sunlight can provide vitamin D, but not when sunscreen is used. Obesity can contribute to joint problems and also poses a risk for hypertension, heart disease, and stroke. Make your meals more enjoyable for your patient in the long-term care setting by serving the food in an attractive manner and making the environment as pleasant as possible. A nutritionist can also help with determining any nutritional needs. Tube feedings or parenteral feedings may have to be used if attempts at oral feedings are unsuccessful. Patients with dysphagia or difficulty swallowing are at a higher risk for developing a nutritional deficit. To avoid any aspiration, always position your patients with dysphagia upright or in a high Fowler's position and feed them very small amounts. You may even thicken the liquids if it's recommended by the swallowing evaluation. Instruct the dysphagia patient to tuck their chin when swallowing. Keep the patient in an upright position for 45 to 60 minutes after eating. Provide a stress-free environment because stress can make dysphagia even more pronounced. Age-related eye changes can be debilitating if they're not recognized and corrected. Visual accommodation, or the ability to focus on near objects, does decrease with age as a result of weakening of the muscles that control the lens. Presbyopia is the age-related decreased ability to focus on near objects. The lens of the eye may yellow with age. This can cause a decline in color perception in our elderly population. The older adult may have trouble adjusting from light to dark vision. As the blood supply to the retina decreases, depth perception, peripheral vision, and night vision will decrease. Glaucoma, which is a common disorder of the eye, is the accumulation of fluids inside the eye that increases pressure on the optic nerve, can eventually Cataracts occur to some extent in almost all older adults, but especially so in our patients with diabetes. Age-related macular degeneration, or AMD, is a condition in which the older adult gradually loses acute, central, and color vision. There is no cure for this condition. Measures to enhance vision would include the use of medications, surgery, and prosthetic devices. There are many degrees of vision loss, and interventions are geared to promoting the individual's return to maximum independence. You must orient the patient with any vision loss to a new environment to avoid any potential confusion and anxiety, as well as reduce the incidence of accidents. Inform all health team members about the patient's visual deficit. Do not rearrange the room or the patient's personal belongings without permission or explanation. Speak before handing an object to them. To promote independence in eating, describe the positions of the food on the plate in relation to a clock position. When walking the patient with a visual impairment, offer your arm for guidance. Pause and explain any environmental changes, like steps, to decrease the fear of new surroundings. Screen magnifiers, large print books, talking books, large number watches, clocks, and telephones are examples of aids that can be beneficial. Bright, glare-free light is necessary for the older adult to move about safely. Regarding patient and family education, all interventions to assist the patient with independence need to be explained to a family member who lives with the older adult at home. A common concern of the visually impaired older adult is the one who continues driving. This will create a psychosocial issue that involves not only the older adult and the family, but also society as well. In coping with this concern, many states and provinces will now require special testing before reissuing licenses to those over a certain age. Individuals may be given licenses that restrict driving to specific distances and areas. Encourage elderly people who still drive to avoid night driving and to wear prescribed hearing aids and glasses to help enhance their sensory awareness. Advise older adults not to drive under the influence of alcohol or drugs and to avoid driving in bad weather to avoid any accidents. The inability to hear high-frequency sounds typically becomes noticeable by late middle age. Presbycusis is the inability to hear high-pitched sounds and the inability to hear spoken words. Tinnitus or ringing in the ears can also cause further loss of hearing. Presbycusis is commonly exacerbated by earwax accumulation. Removal of a wax impaction can make a big difference in the elderly adult's hearing ability. It is of utmost importance to frequently assess whether or not earwax is contributing to their hearing loss. Hearing loss can lead to ongoing frustration and embarrassment for the patient. This becomes an important concern when attempting to communicate with them about any health-related issues. If the patient has a hearing aid, the nurse should know how to operate it. The hearing aid should be free of earwax and fit properly in the ear canal to function correctly. Communication with the person with hearing loss can be difficult for the patient and the nurse. Face the patient so they know you are present. Speak clearly and distinctly in low tones. Rephrase sentences as needed. Facial expressions and gestures can be helpful in communicating messages. Conduct your conversations in a well-lit area with minimal outside distractions. Speak towards the patient's good ear if possible. Keep environmental noise to a minimum to avoid confusion and improve the clarity of conversation. Use a pad and pencil if messages are still unclear. Family members may become frustrated with an older adult who will not get a hearing aid or who will not wear the hearing aid to communicate. In those instances, we just want to provide as much education as possible, but allow them to make their own decision. People will continue sexual activity into old age. Changing health status, age-related physical changes, and loss of a sex partner do affect the sexual practices of our elderly population. Sexual response time will slow with age, but the ability to achieve orgasm continues. The decreased levels of hormones can result in discomfort or pain, also known as dyspareunia, during intercourse for the elderly woman. Thinning and dryness of the vaginal walls will also predispose the elderly female to vaginitis. The older man may experience a slower sexual arousal, but many resources are available to help the man achieve erection. Chronic illness or disability can also affect the partner's ability to participate in any sexual activity. One concern is the rise of human immunodeficiency virus, or HIV, and other sexually transmitted infections in our elderly adult population. Older adults may not practice safe sex because pregnancy is no longer a concern. It is not uncommon for some older adults to strike up a romance within an assisted living facility or a long-term care facility. It's important to continue to provide education on STIs to this population. The greater the number of medications consumed by the patient, the greater at risk they are for any undesirable reactions, drug interactions, and toxicity. Polypharmacy is the use of multiple medications, often inappropriately and excessively, at the same time. This can often occur if the patient sees multiple doctors and each is unaware of what the other is prescribing. It can also occur if the patient uses a local pharmacy and a mail order pharmacy, so the pharmacist is not aware of all the drugs the patient is consuming. Individuals older than 65 years of age are also the largest users of prescription and over-the-counter drugs, and therefore are more likely to experience polypharmacy as well. In the elderly person, drug interactions and toxicity can result in behavioral or cognitive changes that could be mistaken for dementia. Many factors related to aging will alter the rate at which drugs are metabolized and excreted. Absorption, storage, and serum binding factors all affect the way a drug is used by the body. The risk for toxicity can significantly increase if the elderly adult is malnourished because medications are metabolized more slowly when the diet is inadequate. Aging kidneys are significantly less effective in excreting drugs, resulting in elevated drug levels and symptoms of toxicity. A thorough medication history is the initial step in preventing polypharmacy. Specifically, ask the patient questions to obtain information about their patient's current prescriptions, over-the-counter drugs, and any vitamins or herbal preparations being taken. Ask the patient to bring a bag full of all the medications they take at home. Assessment data should also include the patient's current administration schedule, knowledge about their medications, any medication-related problems, non-adherence problems, frequency of care provider visits, sensory deficits, mental and physical abilities, the ability to purchase and obtain medication, and the use of alcohol and caffeine. Ideally, a pharmacist or a doctor or nurse practitioner would address these questions, but the nurse should be prepared to initially assess the patient's medication history and then continue to gather information from there. Attempt to reduce the complexity of the medication regimen by improving the patient's self-medication practices. One frequently used medication reminder system is the daily or weekly pill container available at pharmacies. A homemade egg carton container could be a good alternative to a pill box for a patient with arthritis. Other reminder tactics would include the use of check-off systems, calendars, color or symbol-coded medication bottles, an alarm clock, or a voicemail system. The use of cueing medications with daily events, like brushing teeth, can also help promote adherence. So that's it for chapter 40. I'm going to go ahead and share my screen and show you the answers to the pretest, which you are responsible for doing on your own. And these are the answers to chapter 40 pretest. All right. Okay, continuing on, chapter 41, our very last chapter in this textbook. Not that we finished the entire textbook yet, but we will finish it by the time that we're done with Foundations 2. So we're getting close. The psychosocial status of the older adult is influenced by several factors, including functional ability and external forces. Cognitive impairments like dementia and physical care problems, such as altered mobility, are examples of functional limitations. External forces can include economic and environmental factors like income, housing, technology, geographic area, community resources, and crime. Individual life circumstances, like a lack of support system or loneliness and depression, can lead to the overuse of alcohol, which can influence the older adult's overall well-being. These factors, individually or in combination, will all affect the way an older adult perceives the healthcare system and ultimately responds to illness. People often assume that mental confusion and forgetfulness are a typical fact of aging. However, few cognitive changes are actually attributable to age-related factors alone. Some memory functions do change with age. The changes with age include a decline in short-term memory, a decrease in episodic memory, which would be personal events, and a slight and gradual decline in cognitive skills, like word fluency, logical analysis, selective attention, naming of objects, and complex visuospatial skills. Recall of facts and general knowledge does not change with age, nor does the performance of cognitive and motor skills, although they might occur a little bit more slowly. Older adults are just as capable of learning new things as younger people. It's just that the speed of processing information is a little slower. Examples of mental changes that are not due to normal aging include confusion, disorientation, inappropriate behavior, depression, and the inability to concentrate or follow directions. The older adult with significant changes in mental functioning should be given a comprehensive mental status examination using a tool like the Short Portable Mental Status Questionnaire or the Mini-COG or the Mini Mental State Examination. As a nurse, you need to understand that disorientation and other mental symptoms can have a physiologic basis. Be patient and allow enough time for the older adult to respond to your questions. Assess for factors that may contribute to an altered mental state, like medication effects, a new environment, disease processes, or psychosocial stressors. Mental confusion can significantly influence a patient's dignity, independence, personality, and support system, and can complicate diagnosis and treatment of an illness. Confusion can be caused by delirium, dementia, or numerous other reversible conditions. Delirium is a state of acute confusion that can occur suddenly or over a long period of time as a result of an underlying biologic cause or physical stressor. Delirium is reversible. Causes include stroke, tumors, infection, fluid and electrolyte imbalance, acute inflammatory disorders, alcohol, drug reactions, toxins, sensory deprivation or overload, hospitalization or surgery, and depression. Nocturnal delirium can also be known as sundown syndrome or sundowning. This is the appearance or symptoms of confusion or agitation in the late afternoon or evening hours and typically continues on into the night. Impaired mental status, dehydration, fatigue, low lighting, or increased shadows can contribute to sundowning. Dementia is a permanent condition characterized by several cognitive deficits. It's characterized by a slow, insidious onset that affects memory, intellectual functioning, and the ability to problem solve. Symptoms of dementia can mask depression. The reverse is also true. The depressed person may be seen with symptoms similar to those of dementia, such as confusion or disorientation. The cognitive losses associated with dementia, delirium, and depression are similar, but patients with each condition experience cognitive changes at different rates, and they will respond differently to interventions. A behavioral approach is essential to enhance the quality of life for an older adult with confusion or disorientation. The two types of behavioral management are psychosocial intervention. The primary goal of psychosocial interventions is to produce a feeling of well-being in the confused and disoriented adult. A variety of therapies can help patients who are experiencing confusion and disorientation to regain their sense of who they are and what is happening in the world around them. Once a therapy is initiated, it should be used consistently by everyone in contact with the patient, including the family, to avoid any further confusion. Other psychosocial interventions include the use of creative expression therapies, like art, music, and humor that can allow for self-expression, alleviate depression, and improve the quality of life and emotional status. The goal of creative expression therapies is to slow the rate of deterioration and prevent institutionalization for as long as possible. Having pets available can also meet many needs, like companionship and the need for touch. Before administering, some additional psychosocial approaches for confusion and disorientation can be seen on page 851 in table 41.2. And all of those things are very important, especially encouraging socialization patterns within a group. Before you start administering medications to deal with any problem behaviors, you need to first implement all other types of nursing interventions and document their effectiveness. It's important to use drugs for valid psychological problems, and not just for annoying behaviors. Many psychotropic drugs will require an extended time to have a therapeutic effect. Major tranquilizers are also known as antipsychotics, such as chlorpromazine or haloperidol, can sometimes be prescribed for a patient but they should only be used if the patient has mania or psychosis, the symptoms create a dangerous situation for the patient or others, and the patient is in extreme distress and there is great difficulty receiving the needed care. The U.S. Food and Drug Administration, or FDA, has ordered that a black box warning be placed on all antipsychotics, indicating that they are not approved to treat dementia symptoms. They increase the risk of death in the older adult. The black box warning is the strongest advisory the FDA makes, indicating a serious or life-threatening risk to the consumer. If an antipsychotic is prescribed, patients need to be closely monitored. Minor tranquilizers can also be used to treat symptoms of agitation and anxiety, although many medications in this category appear on the others. As caregivers, the entire family often experiences changes in lifestyle, privacy, socialization, and family dynamics. The caregiver can experience physical and mental exhaustion from providing round the clock care. Adjusting to the reality that dementia is a chronic, irreversible condition that may result in lingering death can be difficult. This places families in a situation of dealing with grief over a very long period of time. Acceptance of a relative with dementia will depend on personal coping strategies, support, and past experiences. Family members will need ongoing support by the healthcare team. Financial problems and multiple role responsibilities will add to the burden of caregiving by the spouse or the adult children. Caregivers should be encouraged to take time for themselves and attend to their own well being. Nurses can encourage families to consider adult day services or respite care if the older adult resides at home. Provide guidance in locating resources for the family to explore. Alzheimer's is the most common form of dementia, estimating a range of 60 to 80% of total dementia patients in our older adult population, and it is the fifth leading cause of death in this population. The loss of neurons in the frontal and temporal lobes accounts for the Alzheimer's patient's ability to process and integrate new information and retrieve memory. Treatment for Alzheimer's disease is primarily symptomatic. We use three cholinesterase inhibitor drugs: donepezil, galamentine, and rivastigmine. These produce modest benefits early in the disease by improving memory, alertness, and social engagement. Mementine or Namenda is also another form of medication thought to protect nerve cells from excess stimulation and delay the progression of symptoms. This was the first treatment option for moderate to severe Alzheimer's. Other medications found to enhance cognitive functioning and improve behavioral problems include vitamin E, folic acid, and possibly NSAIDs, as well as cholesterol-lowering statin drugs. Generally, nursing intervention in Alzheimer's patients will depend on the severity of illness. Early in the disease process, nursing care for a confused patient is necessary. Later on, nursing care is primarily supportive. When an older adult is cognitively impaired, home safety becomes an issue. There need to be adjustments to the living situation. Measures will need to be taken to alert the household if the person leaves the bedroom area at night so that the stove is not used with supervision. Alarms should be placed on outside doors to prevent the person from wandering alone. Sometimes residential placement is needed. If the older adult owns a car, driving is another. States will have limitations on older adult driving. One way to help is suggesting a family member take the person wherever they want to go for 1 month, so that it can become apparent to the patient that giving up their car doesn't mean staying at home. Violent behavior in the older of a lifelong psychological pattern, an organic condition, or an adverse reaction to medication. Aggressive behavior can also occur as a self-protective response to confusion, fear, pain, or sensory loss. Behavior is a form of communication. Nonverbal behavior, like agitation and restlessness, can be an expression of unmet needs, like thirst or pain. It's our responsibility to facilitate communication and determine if there are any unmet needs. Agitation can be prevented and managed by watching carefully for signs, like increasing irritability or sudden explosive outbursts. Before an actual outburst occurs, try to engage your patient in conversation, of course using your therapeutic communication skills. Match the patient's tone of voice, and this can be calming. It also can be advisable to step back about 4 to 6 feet when conversing. Behavior modification is an intervention used to change agitated behavior by giving positive feedback for desired behaviors and negative feedback for undesired behaviors. If a patient becomes violent, you must remember to protect the patient from their own behavior. You need to call for help and decide what intervention will be most effective. Points to consider for an intervention are the patient's right to the least restrictive treatment, and of course, federal and state regulations regarding the use of chemical and physical protective devices. Before giving any medications, it is necessary to try behavioral approaches and document their effectiveness. When all else fails and the patient poses a threat to their own well-being or to others, protective devices are necessary. Paranoia can be caused by delirium, dementia, and psychological conditions such as schizophrenia. Patients with paranoia may misinterpret their environment and believe that others are untrustworthy or out to get them. For the patient with paranoia, developing trust is the most important approach. Do not make any promises that you cannot keep. If you say that you will do something, follow up and do it. Wandering may be a problem for the patient affected with a cognitive disorder. Nursing interventions would include ensuring that the environment is safe for wandering, informing and educating others about this problem, ensuring that the patient has an ID bracelet, frequently checking the patient, observing for any behaviors that would trigger the wandering, diverting their attention, and maintaining a regular activity program. To alleviate confusions and fears associated with sundowning, it's important to help the patient feel safe in their environment. Use a nightlight, place the call bell within reach, reduce any stimulation from the environment, and move the patient closer to the nurse's station. These are interventions that can help minimize nocturnal confusion. Adequate nutrition often becomes a problem for the patient with dementia. On page 855, you can see some strategies to improve the nutritional status of the cognitively impaired older adult. That's going to be under the Patient Education tab at the bottom of the page. Depression in the older adult is often overlooked and untreated. It is the most common functional mental illness in older adults, but it is often mistaken for delirium or dementia. It is difficult to recognize because symptoms can be attributed to the aging process. Depression in the older adult also occurs to a greater degree as a result of situational factors, such as multiple losses. Undiagnosed and untreated depression is a major contributor to alcohol use disorder and suicide in the elderly adult population. Alcohol use disorder, suicide, and depression are interrelated in that they each have similar risk factors associated with multiple losses. Loss of status and power, income, spouse, friends, health, and mobility can contribute to feelings of despair and hopelessness. A suicide attempt is more likely to be completed Clues to alcohol use disorder include depression, insomnia, mental confusion, frequent falls, self-neglect, uncontrollable hypertension or diabetes, along with gastritis or anemia. Patients who are depressed are usually treated with psychotherapy and antidepressants. Hospitalization may be necessary if the patient is at risk of suicide. We have 5 main categories of medications used to treat depression, and 3 of them are pretty newer categories of antidepressants, typically our first-line therapy. You can see examples of the antidepressants on page 857, and make sure to pay specific attention to the contraindications for those medications. Electroconvulsive therapy, or ECT, consists of electric shock to the brain delivered via electrodes and attached to the patient's temples, intentionally triggering a brief seizure that seems to alter brain chemistry and improve symptoms. The primary nursing responsibility for a depressed patient is to protect them from self-injury, especially after the patient has initiated antidepressant therapy. Before that time, they might not have had the energy to complete suicide. Once they are on antidepressant drugs, they may now have the energy to carry out their wishes. It might be difficult to communicate with the depressed patient because of their negative thoughts and behaviors. Genuine concern for the patient is essential. Remember that goal setting and problem solving take concentration and energy that might not be available to a person who is still depressed. Caregivers need to be alert for potential signs of suicide, like meticulous planning of personal affairs, giving away treasured possessions, sudden euphoria, or statements about death wishes. You must build a trusting relationship with the suicidal patient to let them know that you care. If a patient makes any reference to suicide, you need to ask directly whether or not they're planning to end their life. Questions such as, do you want to hurt yourself? Have you thought about hurting yourself? What are the questions we ask? Just let me think for a second on the CSSR. Have you ever in the past, one of the questions that we asked is, have you ever in your lifetime thought about, planned to, or taken steps to actually end your life? We say within the past 3 months, have you thought of hurting yourself? I can't remember the questions exactly. I'll have to take a look when I work tonight at the CSSR, and then I can tell you guys when we discuss this in lecture and in the Sims lab when you come back from summer break. But always being matter of fact and asking directly. Don't dance around the question. It's important. We need to know. Ask the direct question. During the admission patient interview, you need to assess the use of alcohol by the depressed older adult. Once the patient is stable, you may be able to start therapy such as group behavioral or individual therapy to help with any depression, loneliness, and loss, as well as to help build a social network for that patient. Patient and family education should also include information about the effects of alcohol on medications and chronic health conditions. Refer the patient to a 12-step program, such as Alcoholics Anonymous, for the patient, and Al-Anon for family members can be a beneficial part of the treatment. Abuse is defined as the intentional infliction of physical or emotional discomfort, or the deprivation of basic necessities for comfort and survival. It is estimated that only 1 in 14 cases of elder abuse is reported. Elder abuse is most often inflicted by a spouse or adult children in the home, and it is often undetected. It is often related to caregiving stress, unresolved family conflicts, unhealthy family dynamics, or families with a history of abuse. The nurse's responsibilities include identifying those at risk and then reporting the suspected abuse. During assessment of potential abuse, avoid a condescending tone of voice or any judgmental expression. Establish a confidential and trusting relationship. Demonstrate willingness to listen to the caregiver's perspective as well. You are required by law to report elder abuse and are protected from civil liability in most states that mandate reporting of suspected abuse, as long as you make the report based on reasonable suspicion and in good faith. Report any suspected abuse immediately to the appropriate agency for investigation. The standard for reporting is usually a reasonable belief that an individual has been or is likely to be abused, neglected, or exploited. You can face misdemeanor charges and jail time if you fail to report any suspected or identified abuse. A common frustrating situation is when the competent older adult with full legal rights refuses help or wishes to remain in the environment that is unsafe or unacceptable for them. In this case, the healthcare team needs to provide counseling about possible dangers, but at the end, honor the patient's decision if the person is mentally competent to make it. Individual and/or group psychotherapy can be used to treat victims and abusers. Support groups are also available. Crime is of particular concern to our elderly population because of their vulnerability. Older adults may fall prey to internet scams, like receiving emails from somebody posing as a relative from a foreign country who has lost their wallet and passport. Some of the crimes against older adults are listed in Box 41.9. Also take note to the patient education on page 858. Crime reduction suggestions for older adults. Those strategies are very important, especially like not letting strangers at your door or not letting people on the telephone know that you're home alone. And do not give information to strangers over the phone. Just hang up and report any nuisance callers. Also take note on page 858 at box 41.8, the categories of elder abuse. Nurses can help reduce the patient's fear of crime by assisting older adults in exploring some security-conscious behaviors to decrease their vulnerability to victimization. It's important also to learn about referral programs in crime protection, prevention, and victim assistance. Older adults will be the fastest growing segment of the population and will have the greatest effect on the delivery of healthcare. Older adults of tomorrow will be better educated, more involved in community and political activities, more internet savvy, and more knowledgeable consumers of healthcare. Expanding present services and developing new delivery systems will be challenges for our future. And that's it for chapter 41. I'm going to go ahead and show you the pretest answers. And these are the answers for the pretest to chapter 41, and the pretest is available to you in Blackboard in week 12. Okay, that concludes this recorded lecture. Thank you.